Everybody. This is Dr. Datteshwar Hota. I am the Dean and Principal of SME Medical College, Cuttack. I feel privileged to welcome you all to this pre-platinum Jubilee CME of SME Medical College, Cuttack. The college was established in 1944. We are in the 77th year, but unfortunately, because of the corona pandemic, the Platinum Jubilee could not be celebrated. Even though this year, corona has not spared us, we thought we will not further delay. And we took it as a challenge. Even during the corona time, our Platinum Jubilee cannot wait further. Dr. Alkandu Ghosh, the president of the ERA, Dr. Ramnath Mishra, Dr. B. Koniti Rao, and many more eminent rheumatologists and immunologists of the country and outside. Dr. P.D. Rath, the speaker, Dr. Manish Ramesh, the speaker. I learned that they passed from this SME Medical College, Dr. Rath, in 1997, his MBBS, and 2003, his post-graduation in medicine. Dr. Manish Ramesh, who passed out in 2000. You are all proud. We are all proud of you. You are all proud alumni of SCV. Incidentally, it occurred to us that since we are going to celebrate the Platinum Jubilee, why not to have a pre-Platinum Jubilee academic bonanza, extravaganza, whatever you put it. The thought came to us and we thought, let's reunite our alumni across the world on an academic platform, and that too in a digital platform, which is now the new normal. And Corona made us to realize that it is possible that we can reunite despite its havoc. Now, I welcome you on behalf of the institution. You are part and parcel of this institution. I also invite all other participants, even though they are not part of the institution, I invite them on behalf of the institution to please join us in our Platinum Jubilee celebration on 26th, 27th, and 28th. All program will be live streamed. The same way we can always get connected through this digital platform. With these few words, now we have already crossed the middle path. Already 19 departments, they have completed their presentation. Today is the day for the Department of Rheumatology. I have been very much associated with the Department of Rheumatology because Professor Bidyut Das is much known as Bidyut Bhai here. And he is an astute cricketer. He was a batsman par excellence. And you know, you bowl any googly to him, he has an answer to that by throwing the ball to the boundary. The fact is that we are known to each other for pretty long years now. It is more than 4 decades. And I have known him so thoroughly, I thought I'll speak a little more than I usually speak. And I can tell you that we have a jewel in him. One Department of Rheumatology, which erstwhile is rheumatology, now as part of MCI, I know that the terminology has changed to clinical immunology and rheumatology. And for the good reason it has been changed. A lot of confusion was occurring when the rheumatology and the immunology were different. A lot of confusion was occurring. So at least God gave me the opportunity to amalgamate both. And now it is known as clinical immunology and rheumatology. Now, all of you know, now whenever we talk about any disease excepting, or maybe the oncology also, the immunology of oncology also equally important. Any disease we talk about, immunology plays a major role. Now, not only the treatment, the prophylaxis is based on immunological aspect of management. So we have today the juggernaut. A lot of people do not know what is the immunology and how we are going to benefit from immunology. I believe today's deliberation will enlighten one and all and definitely be useful. And especially when I say about this, especially to the faculty and students of SCV Medical College, Cuttack. With these few words, I extend my warm welcome again and hand over to our moderator, Professor Bidyut Das, to conduct the proceedings.
Thank you, sir. Good afternoon, good evening, good morning, wherever you are. I know there are people from all over the world who have joined. Respected Dean Sir, our esteemed colleagues from all the departments, my students, and my special mention of my mentor, Professor R.N. Mishra, who was instrumental in putting me in immunology, an eminent immunologist of the world. My friend and colleague, President of the Indian Rheumatology Association, Professor Alkendu Ghosh. Thank you, sir, for joining. All my dear friends and colleagues from the East Zone Rheumatology Association, which includes Sanjeev Kakati, my close friend who's the Dean Principal of Dibrugarh Medical College, and many more friends, colleagues across the country and across the world. I'm really indebted to you for having accepted my invitation and for joining this pre-Jubilee celebration. For me, it is a momentous occasion because the Department of Rheumatology is still a toddler. We started long back, but it gained importance around 2011, it was recognized by the government as a department. So it has taken me 23 long years of struggle to establish the department. And we are catching up pretty fast. That's for sure. Most of my colleagues would agree that we have come a long way, but still we have to go a long way. This department, as Professor Hota said, has been misunderstood. Rheumatology, and I joined, people ask me, what does it deal with? People think it's all about joints. That is where the problem starts. And we were considered to be the poor cousins of orthopedics. Maybe we were considered as UFOs, unidentified flying objects. Nobody knew much about that. Professor Hota, the dean and my friend, was instrumental in changing this when he was a very influential member of the MCI, erstwhile MCI, to change the connotation from rheumatology to clinical immunology and rheumatology. Now, all across the country, it is known as clinical immunology rheumatology. And I can tell you, our contribution to every department of medical science is quite immense. And you can see from the presentation that the two of the presenters will make, you can realize how important rheumatology and immunology is to medical science. That is why we named the topic the juggernaut, which actually goes into everything. So today I have the opportunity to present two brilliant exponents of this subject. Both of them are SCBians. Both of them were my students, and I'm very proud, and we are all very proud of you, both Dr. Manish and Dr. Prasandeep. The first speaker today is Dr. Prasandeep Rath. After passing MBBS in '97 in Cuttack, SCB, he did his MD. But these are the years when he spent a lot of time with me. He joined a fellowship in NIMS, Hyderabad, and subsequently he rose up the ranks and currently is the director of the DME Rheumatology Training Program, Max Hospital, New Delhi. He's also an examiner of the MRCP DNB Rheumatology. He's widely known in the country as an extremely brilliant rheumatologist. He's the clinical educational supervisor for core medical training leading to MRCP. He's the first rheumatologist in India to be EULAR certified, that is the European League Against Rheumatology, in musculoskeletal ultrasonography. He is the first guy. He has published more than 50 papers in national and international journals, including book chapters. He's the guest editor of MSK Ultrasound Supplements of IGR. And I'm no doubt the presentations that will make everybody understand why rheumatology is so important in modern science. The mic is yours, Prasandeep. You can take over.
Thank you, sir. Thank you so much for that kind introduction. And we've always derived our inspiration from you. I think it's a very nostalgic moment for us. You know, our batch, if I remember, and I must start by saying that I would like to thank all my classmates. You know, I'm not a very social media person. I'm not into those social media groups. So I talk very less often with my friends, but I must say, take this opportunity to thank all my classmates for that wonderful time that we had in the 90s, and the 90s belonged to our batch. Our batch was unique in many ways. It was the first batch which won the entire election. So we defeated the fourth year, then we were in the third year. We also had the privilege of being part of the Golden Jubilee celebration. And I still remember those days, we were on the stage. I used to be singing a song, We Didn't Start the Fire. That was one of my favorite songs I would sing. And so with that, those were different days. And then I think we had a lovely time at SCB Medical College. And the other thing I would like to start by is, paying a tribute to all my teachers. There may be colleges which are bigger than SCB. There may be colleges which are beautiful than SCB, but there was no college at that time which I think had better teachers than SCB. I mean, starting from anatomy to physiology to biochemistry to pathology, microbiology, you name it. Each one of them were doyens, and they inspired us, and they keep inspiring us. When I was a student, I used to think, why do I need to learn a limb anatomy? What has got to do with me? I'm never going to be doing anything with that. I was very clear in my mind, I never wanted to be a surgeon. But when I started reading MSK ultrasound, all that came back to me, and I could see the faces of my anatomy teachers. And my teachers in gynae, and I'm not going to name one because I would have to name all of them. Gynecology, eye, in eye, we used to get so mortally scared of uveitis. That was a favorite question of the examiner. We never understood anything. And today, uveitis is the bread and butter for a rheumatologist. And when I entered the medicine department, I think that is when I knew that I had to be an internist. I mean, being MBBS and MD from there, I have had the opportunity of interacting with all the doyens, from the professor to the last lecturer in internal medicine. And I tell you, what a wonderful teachers they were. Their aura, their style. Somebody was good in immunology, somebody was good in diabetes, somebody was good in hematology, somebody was good in infectious disease. And there was so much to learn from each one of them. And not only learn, they had a very charismatic personality, which I think is I don't know how much of it is there today, but really inspired me, and I fell in love with this science. So my tribute to all my teachers, because wherever I go and whatever I am, is because of that firm knowledge that I could have got nowhere. I could have got more beautiful universities maybe, but I wouldn't have had such teachers in my life. So I'm really indebted to them. And with that, I would like to start my talk. So basically, let me just share. So when we talk about rheumatology or immunology and rheumatology, people think of rheumatology as a fancy science. You have to do fancy tests and you make a diagnosis. That's not true. Rheumatology is still the purest form of clinical medicine. And what makes it that is, it still depends largely on a good clinical history, a good clinical examination. And that is what makes a rheumatologist stand apart, and still the last bastion, I would say, of internal medicine. And I've taken few short and sweet cases because we don't have much time. Normally, when we take cases, there are a lot of pulmonology, neurology, interactions. But I think those cases are long, protracted. We have to present. We don't have much time. So I'll take short and sweet cases, and each of these cases will highlight to you that you don't need fancy investigations to make a diagnosis. You need to take a good clinical history and good clinical acumen. And as I said, these cases may have some very good images, which I feel are good because I think images speak more than 1,000 words. So with that, we'll probably move to the first case. Right, so this was a patient, and this was way back in 2008 or 9. This was patient referred from another hospital, admitted under our physician as a case of parotitis with facial cellulitis, with periorbital swelling. There was incision and drainage done under local anesthesia and sedation. Patient had presented with pain and swelling on the right side of the face and neck since 4 weeks and fever for 3 weeks. So this was the lady, and there was a gross, huge swelling on one side of the face. There was angioedema on both sides of the face. So you can see this very ghastly looking picture. She was crying. She had undergone multiple treatments. She had taken antibiotics. You can name it. She had multiple courses of antibiotics, and I don't want to go into that. Ultrasound showed a gross swelling of the right parotid with edema of the overlying skin and soft tissue. Possibly cellulitis was a diagnosis with few sub-centimeter neck nodes on the right side. And you can see the entire right side of the face grossly swollen. The eyelids were so hugely swollen that she couldn't even open her eyes. The CT next with contrast showed diffuse enlargement of the right parotid gland. There was swelling of the right masseter, buccinator, and sternocleidomastoid. There was gross edema of the overlying soft tissue of the right face with multiple mildly enlarged lymph nodes, right submandibular, upper and middle jugular, erosion of the alveolar cortex, and of the portion of maxilla. So you can see gross parotid swelling, submandibular swelling. So huge swelling of the parotid, masseter, and lot of subacute edema on the right side. So with this, the physician, and luckily my physician was somebody who had a training or who had an exposure to rheumatology. So whenever there's a difficult case, he would always involve me, and he still does. So the hemoglobin was around 10.9, plate weight was 1.5, TLC, there was a drop of 2.9, there was another TLC of 5.9, CRP not much, serology for Hep B, Hep C and all was negative, urine was normal, KFT, LFTs, OTP was slightly raised than PT. So that's how a rheumatology assessment took place, because there was no improvement despite multiple courses of antibiotics. So we took the history. There was a 39-year-old female who presented in 2003 for the first time with fever and high grade for a month, followed by nodular swelling of the left leg. And that time a biopsy was done outside, which showed fibrinoid necrosis of the vessels. Query medium vessel vasculitis was the diagnosis. She was treated as cutaneous span for 3 years on steroids, initially methotrexate and then cyclophosphamide. She had recovered subsequently and stopped all treatments. After 3 years of stopping the treatment, she developed multiple erythematous nodules in the arms and legs. Biopsied at All Institute of Medical Sciences was paniculatus. Autoimmune workup was characteristically normal. So ANA was negative, dsDNA was negative, ENA profile was negative. She was treated with steroids and deflazacort for a year, which according to her, she gradually tapered and subsequently stopped. In October 2013, she developed fever and swelling. So I think this was 2013 probably. Developed fever and swelling of the right side of the face, painless, swelling of the eyelids and darkening of the right side of the face. She was not a known diabetic. She had no hypertension, no weight loss, no loss of appetite, no Raynaud's, no oral ulcers, no hair loss, no arthralgia or arthritis, no history of serositis or seizures, no history of any jaundice or anemia. There was history of unspontaneous abortion in the first trimester. She was afebrile. There was an indurated lesion on the right side of the face, which was non-tender. There was angioedema of both eyelids. And that non-tender swelling made us think that this was definitely not infection we were treating. And there were some clues on the face, which a rheumatologist would pick up. But for the general audience in general, we thought of that time as paniculatus, we thought of discoid lupus, and we thought of sarcoidosis. So when we sent our labs, again, the hemoglobin, TLC platelets were more or less normal. The KFT and LFT was mildly deranged, but more or less okay. The ANA and ENA profile were negative. Lupus anticoagulant, cardiolipins were negative, complements were normal. CT chest was done, which was again normal. And at this time, we had something in our mind, and which looked apparent from the face, actually some lesions there, and we asked for a biopsy. And I would like to thank my pathologist, Dr. Abrari, for sharing me these images. So what they basically found was there was focal epidermal atrophy, there was follicular plugging, and you could see a lot of lymphocytic paniculitis or lymphocytic infiltration with some hyalinizations here and there. So this was basically lymphocytic lobular paniculitis with follicular plugging, suggestive of lupus profundus. So lupus profundus is a rare manifestation seen in 1 to 3% of patients. They're mainly women. It's commonly seen in the face, arms, buttocks, and shoulders. Most commonly presents in association with chronic cutaneous lesions of discoid lupus. And in most cases, however, the serological evidence of lupus may be lacking. So it's very important to understand that everything is not ANA positive, need not be ANA positive. In more than 50% of cases, the histopathological clues to the diagnosis is in the form of typical changes of chronic discoid lupus, including epidermal atrophy, follicular plugging, interface changes, thickened basement membranes, and then associated with a lobular lymphocytic paniculitis, which can also occur in isolation, which may be present in with these epidermal changes or without them. The lymphoid follicles with germinal center formation, which is also rarely seen in other forms of paniculitis, except for T-cell lymphoma kind of paniculitis, are present in almost 50% of cases, and they're highly suggestive. So lymphocytic infiltration and nuclear fragmentation is a clue. Hyaline sclerosis of the lobules with focal extension into interlobular septa is another clue. So our case was a case of lupus profundus, but was also unique in our case that our case had parotid involvement. And when we looked at the literature, this is very, very rare. So periparotid lupus erythematous paniculitis, where there was one case report, and unilateral parotid mass as an unusual presentation of lupus profundus. So very rare presentation of the parotid or involvement of the parotid. So again, a case which highlights that everything is not serology. Of course, to a trained rheumatologist, you could see some of those lesions on the forehead and you could think that they looked discoid. She was started on steroids and then on, there was very little improvement. Then we gave her azathioprine. She didn't tolerate that. We tried myco, didn't tolerate. And then I went back to an old and wonderful drug that is often used for cutaneous lupus, which is thalidomide. Initially, we used to think of it as a weak TNF inhibitor, but now we know that it acts through cerebellum and acts at the ubiquitin pathway. And that really helps. And now we're using lenalidomide, which is probably less toxic than thalidomide. So with thalidomide, she started to show improvement. And this was what she looked after a few weeks. And then finally, after 2 months, we could actually see her. And now she's become normal. And we presented this as a case at the Eurolupus Congress held at Dusseldorf in Germany in 2018. So with that, I go to the next case. Now, this was a 60-year-old female. And what made her special was she was the mother of my admin in charge of Max. So when you know your boss's mother is sick, things are really bad. She was recently diagnosed as query type 1 diabetes, no response to oral antidiabetic drugs. She was on basal bolus regime of insulin. She was on Novorapid pre-meal, TDS, and Lantus once a day for the last few months with an HbA1c of 6.3. And suddenly from 10th October, her sugars started to rise. It went up to 400 to 520 range. She also developed urticarial rashes on the limbs almost 3 to 4 days before the onset of severe hyperglycemia. She was admitted with an RBS of 515 on arrival in the ER at Max. There was no ketosis. She was admitted under one of our admin's pet physicians. She was given IV insulin on arrival, which reduced the blood glucose somewhat to around 350. She was switched over to subcute insulin again, and on subcute insulin, she continued to maintain a blood glucose of 400 to 500 and then went up to 580. And she was on more than 1 unit of per kg per day of insulin. This is when the endocrinologist decided to start her on continuous IV infusion of insulin by syringe pump. So despite on a high dose of IV insulin, 9 to 13 units per hour, more than 2,400 units per day, her blood glucose still fluctuated between 300, went up to 400, as high up to 511. At the same time, she also developed rashes which were maculopapular, non-pruritic over the extremities, which was different from the urticarial rash. And it so happened that at this point of time, the physician thought, well, there's some rash, something going on, and let's take a rheumatology consult. And my admin then told me to go and have a look at the case. So past history, when we took a meticulous history, we found that she had a history of chronic urticaria and she was diagnosed as cutaneous lupus in Kolkata. The details were not available, but probably she had a diagnosis of discoid lupus or some kind of cutaneous lupus. She had taken HCQs for some time and she had improved and she had stopped medications of late. Her infective screen was negative, cardiac assessment was normal, and that's the time we sent the ANA and the line immunoassay because there was a strong history of lupus diagnosed in Kolkata. The ANA-IF was positive. Speckled 1 is to 320, 2 plus intensity. The line immunoassay showed SMD1 2 plus and Rho 63 plus. She had hypocomplementemia. She had no other features of active lupus in any other organ. So at this point of time, I discussed with the endocrinologist and she actually also talked with me and she said, this is something else going on. I think you should do something about it. And then we ordered for a blood test and I told my physician that I think we should start the patient on steroids. And my physician was aghast. She said, what, are you mad? You're going to put this lady on steroids? She already has a 500 blood sugar. She's going to shoot up. She'll go into coma. She'll die. I said, no, I think, and my endocrinologist gave me the confidence. She said, no, you go ahead. I think your thought process is right. So we had thought of something. And I'll tell you what we thought of. So we started her on steroids, 40 milligrams per day, and hydroxychloroquine and mycophenolate. Now, this was on a lady who had a blood sugar of 500. And what happened next was absolutely dramatic. Within 24 hours of starting this regime, her blood glucose started to show progressive fall from 380 to 220 to 143 over 4 hours. Day 2, her IV insulin infusion was stopped at a blood glucose of 143. Despite that, she developed recurrent severe hypoglycemia and had to be managed with IV and per oral glucose. She was put off insulin. So what was happening? What was the diagnosis and what was the blood test we ordered, which of course took some time. So sometimes when the blood tests take time, as they say, the proof of the pudding lies in eating. So sometimes to test a diagnosis, you actually have to treat the patient. And what we were looking at was type B insulin resistance syndrome, which is a very rare condition seen as a kind of autoimmune disease, mainly seen with autoimmune disorders like lupus, Sjogren's, and rheumatoid. It is due to autoantibodies to insulin receptor. It is characterized by extreme insulin resistant diabetes, refractory to massive doses of insulin, dramatic weight loss. It can cause severe hyperandrogenism, unusual widespread acanthosis nigricans. The syndrome usually occurs in the background of a rheumatological illness such as lupus, Sjogren's, MCTD, or is a paraneoplastic manifestation of malignancy. The treatment is with steroids. Immunomodulatory drugs have been tried, even rituximab and plasma exchange has been tried in refractory cases. And actually, I was so excited about this patient. Subsequently, we ordered. So the anti-insulin antibodies, of course, came, but the insulin receptor antibodies were not available. And it's probably known that anti-insulin antibodies, if positive in such patients, is usually associated with a negative prognosis, though in our case, the patient responded wonderfully. And that time, I remember I was so excited, I actually called Dr. Mishra, Ramdas Mishra, and told him about this. And he also encouraged me and said this was a wonderful case. So this was way back. And finally, we come to the case 3. So as you see, all the cases, there is hardly anything, no fancy test. It's basically a good clinical history and a clinical suspicion that takes you there. Now, this is a 28-year-old male from Afghanistan. Now, we get a lot of people from Afghanistan. There's a lot of medical tourism which happens. Now, he came with history of crusted lesion in the left ear for 1 year. And this was a lesion. So huge crusted lesion on the ear. So in Afghanistan, he was diagnosed as cutaneous leishmaniasis, Chiclerose ulcer. He was given intralesional sodium stibogluconate injections. He received 12 injections on a monthly basis. Not much improvement. The lesions were increasing in size and crusting. So he came to Max, to the dermatology department as usual. So rheumatologists are never the first line of action for most of these patients because they think rheumatology is all about joint pains. So the dermatologist thought of cutaneous tuberculosis, thought of fungal infection, or a cutaneous leishmaniasis. The patient also complained of intermittent joint pains. And so he thought, well, let me just take a rheumatology consult. When we saw the patient, we just took a basic history. On taking a good history, we found that he had blurring of vision 6 months back, for which he had gone to an ophthalmologist. The details were not available, but apparently there was some blurring, and he was treated, and he had improved with it. Again, revisiting the history, he had history of recurrent oral and genital ulcers. So we had something in our mind and we asked for an ophthal opinion. The ophthal opinion was that the patient had retinal vasculitis. And here, I would just like to say one thing. Please remember, and this is for physicians and ophthalmologists both, and I learned this from one of the gurus of ophthalmology, Dr. Rosenbaum. When we talk of retinal vasculitis, when an ophthalmologist talks of retinal vasculitis, they are basically talking of leakage of the angiographic dye. But when a rheumatologist talks of retinal vasculitis, we talk of something called as fibrinoid necrosis, panmural infiltration of the vessel wall. They are two different things. And that is the reason why many of these so-called ophthal retinal vasculitis occurs in actual conditions which are non-vasculitic. For example, birdshot chorioretinopathy has retinal vasculitis, but it's not a vasculitis. So the ophthalmologist's definition of retinal vasculitis is very different from a physician's definition of retinal vasculitis. So please remember, when they're talking of retinal vasculitis, they're actually talking of two different things. Biopsy was planned of the ear, and the biopsy showed lymphocytic vasculitis with pseudoepitheliomatous hyperplasia. There was hyperkeratosis, parakeratosis, irregular epithelial hyperplasia, lymphocytic, perivascular, and periappendigeal infiltrates, palisading histiocytes, and neutrophilic debris. It was negative for fungal, Phyte stain was negative, and negative for LD bodies. So the diagnosis, of course, in this patient was Behçet's and with pathergy, and I'll come to that. So patient was started on colchicine. We put him on steroids and methotrexate, and we left him. He came back after 3 months. It's difficult to come from Afghanistan. So we had put him on moderate doses of steroids and then tapered. He had no response, a very little response. So we thought to put him on azathioprine, and he said, no, by this time, I don't want to go back on steroids. and then we put him on adalimumab. And what happened was, by the end of 6 months, he had a complete resolution of ear lesions. There were no ulcerations, no new lesions. So what we were looking at was Behçet syndrome with pathergy. A note, of course, I'm not a pathologist or a microbiologist, but cutaneous leishmaniasis, it seems, is endemic and a major public health problem in Afghanistan. It is one of the largest focus of anthroponotic cutaneous leishmaniasis. So when we look at pathergy in Behçet's, a hyperreactiveness, we find that they can have mixed type of inflammatory cell infiltrations. They could have neutrophilic rich infiltrations. They could have lymphocytic rich infiltrations. They can also have sometimes lobular panniculitis without vasculitis. Histopathological findings can be erythrocyte extravasation, endothelial swelling and thickening, both leukocytoclastic and lymphocytic vasculitis, pustule formations in the epidermis, lymphocytic vascular reactions, perivascular cell infiltration, and a mixed type of inflammatory cell infiltration. So all these things can happen in pathergy. So this was a patient of Behçet's, and in whom repeated injections of sodium stibogluconate caused the pathergy reaction, leading to hypertrophy. So with that, I would like to end the 3 short cases. So my message again is that very often we don't need a lot of investigations. Simple key history taking is very, very important in most of these conditions. And of course, in many conditions, when in doubt, I've learned one thing from my pathology friends: you must biopsy. And I must say this, that I learned this also from one of my pathology teachers. I will not name him, but when I would be in the OPD, I found him, he used to do FNAC in the OPD, in the old OPD at SCB. And whenever a person would be asked to do an FNAC, a person would come, he would take a history, he would do a clinical examination. I have never seen any pathologist do that in my life. So all the pathologists, in SCB and the people trained are fantastic. I must say that our college is the best. And the more and more I interact with people from other walks of life, I realize how good, how firm our training has been, and how wonderful teachers and colleagues and friends I have made. Thank you so much.
Thank you. Thank you. We will take the questions later on. Put it in the chat box so that I can pick up the questions and ask them later on. The next speaker is Dr. Manish. Manish was here 2000 MBBS pass. He spent most of his time as an undergraduate with me. That is why he used to ask me all kinds of funny immunology questions. He went off to US, did his PhD in immunology at Connecticut, then subsequently did his residency in internal medicine at Jacobi Center, Albert Einstein College of Medicine in New York. Then he did a fellowship in allergy and immunology at Mount Sinai, New York. Now currently is the Associate Professor of Allergy and Immunology at Albert Einstein College of Medicine and Montefiore Medical Center. Also is the Director of Food Allergy Center at Montefiore, Clinical Director of Division of Allergy and Immunology. He has 18 international papers and 1 book chapter. Now he's going to, through his presentations of different cases, how important a rheumatologist and a clinical immunologist is to different fields of medicine. Manish, it's over to you. We must stick to the time of 20 minutes, okay?
Thank you very much for that introduction. I agree with everything that Dr. Prasandeep Rath was saying about the training at SCB, and I would like to add that the one other ingredient in the mix is the patient resource. The number of cases, the diversity of cases you could see at SCB is unmatched. That is something that every medical student should pay attention to, and is only as good ultimately as the number of cases you see and the number of the diversity of cases you see. Um, one of the first things of the so one of the things that I remember from my days in MBBS was that there were all these aphorisms that we used to be told. When I was 17 years old and started at SCB as a new undergraduate, uh, it uh, it didn't make very much sense to me when people would have all these different aphorisms. In every class you would hear something new, and one of the ones that has stuck with me and I'm reminded of every day now in my job is that the eyes do not see what the mind does not know. um, and conversely, um, you learn by seeing more and more cases. Um, and this is particularly a big challenge in immune deficiency disorders. So if you look at the number of immune deficiency disorders that have been described, at this time, this is from an article that was published in 2017, so it's about 4 or 5 years out of date. At that time, they said they described 354 different immune deficiency disorders with about 1,500 gene mutations that genes with mutations that were responsible for them. And this number has expanded rapidly since genetics and genomic testing has become available widely. Now, it's not necessary for everyone to memorize all 354 immune deficiency disorders, but the goal of my presentation is to help develop an approach to when to suspect an immune deficiency disorder and when to reach for help. Luckily, when the mind does not know, the internet comes in to help you. So I'm going to provide you 2 resources that are going to help you with um, approaching or diagnosing these cases. So the first is a series of articles that have been published, I believe, since 2011. And this is an article called the IUIS Phenotypic Classification of Primary Immune Deficiency Diseases. It follows an algorithmic approach, and that either involves certain clinical features or some lab abnormalities, and describes to you how you can go about figuring out what immune deficiency you might be dealing with. This is the PubMed ID if someone wants to note it down, and I'll put it in the chat box later. The second resource I want to tell you about is this website that was made by the University of Pennsylvania called immunedeficiencysearch.com. It is a really good website and picks up a lot of common immune deficiencies quite readily. And here, the way this website works, you would start with one of the features of the presentation. So either clinical features, a particular infection that you're dealing with, the autoimmunity that you're dealing with. And as you click on the boxes, it will take you through a series of steps and then give you a differential diagnosis of what you might be dealing with. So one of the goals of my presentation is to highlight how immune deficiencies usually don't show up at our doorstep for the first time. They usually present to every specialty but immunology and ultimately get referred to us. And then we help make the diagnosis. But they only get to us, as Dr. Prasandeep was saying, if someone suspects and makes that referral. So my goal is to help you determine, to have that suspicion and realize when to refer the patient. So when to suspect a primary immune deficiency disorder? Usually this comes from a few different sources. You could either have typical family history, someone else has similar symptoms, especially with autosomal dominant genetic disorders, that would be the case. You could have typical infections. Either they are infections that are unusually severe, they're uncommon infections, or they're difficult to treat infections that are occurring, or there is as I will demonstrate in a few slides. There could be typical symptoms. So for example, with Chiriakagashi, you'll have certain kinds of um, dermatological abnormalities. Or with hyper IgE syndrome, you're going to have certain skeletal abnormalities. You can also see autoimmunity. Even though these disorders are classified as immune deficiency disorders, autoimmunity and immune deficiency go hand in hand. And the last case I will demonstrate will be about autoimmunity. And finally, you can sometimes pick up certain lab abnormalities and start from there. So today I'm going to focus mainly on infections and the autoimmunity. So this first case is a 31-year-old woman with a history of recurrent sinusitis since she was in her early 20s. When she came to see us, she was working on Wall Street. She had a very busy life. She met a lot of people, but the only thing that she was presenting with was recurrent sinusitis. And she was actually referred because the ENT surgeon who was treating her for her sinusitis sent her for an allergy evaluation. Her allergy evaluation was negative, but when we talked to her, and here again, I want to stress what Dr. Rath mentioned, which is that 90% of my job is history taking. And then the rest 10% is check some labs or physical exam. That's really what it comes down to. So she had been on antibiotics 2 to 3 times a year, which over a decade translates to 20 to 30 courses of antibiotics. And keeps having purulent sinusitis. So she'd never had any pneumonias, no hospitalizations. She didn't have any suggestive family history, but we did check her labs. But before we get to that, I want to tell you about how how you can pick up on certain infectious patterns and help you to narrow down your workup. So instead of sending every test under the sun, what you would like to do is to be able to identify a pattern and test accordingly. So when you are dealing with encapsulated gram-positive Streptococcus, Moraxella, Haemophilus, causing sinopulmonary infections, especially if you are dealing with unusual frequency or unusual severity of infections, your suspicion should be that they could have a humoral immune deficiency. That means either immunoglobulin deficiency or a classical complement component pathway deficiency, which was C1, C2, or C4. So this is the workup you want to send for this patient. We checked her immunoglobulins, and she had almost undetectable immunoglobulins. Keep in mind, this is a 31-year-old working every day, otherwise normal, presenting with only sinusitis, and these are her immunoglobulins. Her IgG, so the graph on the right in blue is the normal range, and in red is her immunoglobulin level. And as you can see, her IgG is very low, IgM was also very low, and IgA was undetectable. When we checked titers against every vaccine she received, she of course had undetectable titers to all of them. And it's always remarkable to me that someone can have some part of the immune system be so diminished, and still their presentation can be fairly mild sometimes. She had a normal B cell count, and this makes the diagnosis of common variable immune deficiency. Common variable immune deficiency is the most common immune deficiency you will see, especially in adults. And if you don't have a clinical suspicion, it's often missed. The lead time for diagnosis, based on many articles that have been published, can be up to 10 to 20 years from the time of initial onset of symptoms, as this case illustrates. The next patient, the next 2 cases are again infectious presentations. So this is a 20-year-old woman originally from the Dominican Republic who came to me with a history of esophageal candidiasis, and she was referred to us by gastroenterology. She walks into my office, she sits down, and she speaks Spanish, so I was using an interpreter, and she tells me that she had been having esophageal candidiasis for 18 years. This is, keep in mind, a 20-year-old girl telling me that she's had esophageal candidiasis for 18 years. So I corrected the interpreter and asked him to check with her again. Did she say 18 months or 18 years? And she said, no, 18 years from the age of 2. She had been on fluconazole, ketoconazole, IV amphotericin, basically every antifungal that was available in the Dominican Republic had been tried. She had been tested for HIV, which was negative. There was no family history of consanguinity. There was no suggestive family history of other members being affected. And when you examined her, she had profound oral candidiasis. So the pattern I want to highlight here is if you are dealing with a recurrent or unusually severe candidal or fungal infection, so it's either mucosal candidiasis or an invasive fungal infection, then the part of the immune system that's most likely broken is either has to do with neutrophils or neutrophilic inflammation. Neutrophilic inflammation is a type of inflammation that's driven by T cells that make the cytokine IL-17. So your problems are somewhere in this region. And here I want to show you how you would use that clinical tool, the phenotypic for phenotypic identification of immune deficiency disorders. So if you go to table 6 in this, you will find that there is a table that says predisposition to parasitic and fungal infections, and specifically there's predisposition to mucocutaneous candidiasis, which is what she's having. And under that, you'll see chronic mucocutaneous candidiasis without ectodermal dysplasia. And this narrows down your list of disorders to a few genetic disorders. So we, of course, did all our labs. She was HIV negative. Her T cell numbers and function were normal. Immunoglobulins were normal. Neutrophil counts were normal. So every test we checked basically for her was normal. And then we developed suspicion for what she would likely have. And the way the diagnosis was made was by genetic testing. So we sent genetic testing for her, and she had a specific mutation in a gene called STAT1. And this is the particular variant that was identified in her. The next step when you do get a genetic test is to see if these genetic tests have previously been reported. So we went back to the literature, and indeed her specific mutation, which was R274W, had been reported and was known to be pathogenic and had the very similar presentation of esophageal candidiasis. So the diagnosis for her was STAT1 gain of function. Now, this is important because now you can actually treat this. If the stats are signaling molecules that are in the same pathway as the JAK-STAT pathway, and now you have JAK inhibitors that are available, and indeed you can use a JAK inhibitor that can reverse the symptoms that are caused by STAT1 gain of function, and it does diminish the immune deficiency that you experience, and this was the approach we used for her. The next case I wanted to show you, so the first case was sinusitis, referred to us by ENT. The second case was esophageal candidiasis, referred to us by gastroenterology. This is a neurology case, actually came to me from neurology. So this is a 65-year-old woman. She presented to neurology with acute worsening of neurological status over 2 weeks. She had had several months of gradual memory loss, difficulty finding words, and this was attributed to aging. But when she had this acute turn of events of over 2 weeks, she went to the emergency room and she had a CT scan, and the CT scan showed a left temporal mass with a right shift that was suggestive of a glioblastoma. Neurosurgery was consulted, and they were called in, and they planned to do a surgery to remove the lesion. When they did craniotomy, they found it to be purulent. And when the pus was sent for culture, they found that she was growing nocardia. So how did a 65-year-old retired woman develop nocardia in the brain? So a little bit more of a background for her. So she's from an insular sort of Christian community, but she has no history of consanguinity. She had some infections in the past. She had some recurrent otitis media when she was a child. She had furunculosis for a while that resolved. She had no history of fungal infections, no history of TB, non-tubercular mycobacterial infections, no history of autoimmunity. She was basically fairly normal until this happens. And when you see an immune deficiency disorder present later in life, you should not only consider primary immune deficiency disorders, but also secondary immune deficiency disorders. We did, in her case, we did do for immunological workup, checking immunoglobulins and other things, and those were normal. But you want to develop a suspicion based on the infectious pattern you're seeing. So when you are dealing with intracellular bacteria, nocardia, salmonella, non-tubercular mycobacterial infections, especially if they're causing for example, non-tubercular pulmonary infections, if they're causing invasive salmonellosis, or presenting with unusual abscesses like this, then the range of disorders that you're dealing with, or parts of the immune system that are likely broken, are limited, and they're usually either phagocytes, which means macrophages and neutrophils, or Th1 inflammation. And this is usually driven by cytokines such as interferon gamma, IL-12, or a cytokine, GM-CSF, which is required for making macrophages. So this narrows down where you are looking for a defect. And at this point, I want to emphasize, so we did all her workup. So we checked her white counts, we checked her immunoglobulins, and all of them are normal. We did see that some of her T cells and B cells seem to be low, but this was because she had been on steroids for the edema around her brain. So sometimes you can be fooled by certain findings, but you have to, again, pay attention to the clinical scenario. Importantly, even though the cell numbers were down, her T cell function was normal, and her immunoglobulin levels were normal, indicating that her B cells were functioning normally. So when you are faced with a scenario like this, so we had a specific suspicion, and the next lesson I have for the for students and for postgraduates is that when you are faced with a scenario like this, collaborate, collaborate, collaborate. So this case was referred to us by another health system, Guardant Health, because they knew we could do the appropriate immunological workup for her, which we did, until we reached a point where we had a clinical suspicion that we did not have an answer for. And at that point, we reached out to NIH, specifically Dr. Holland at NIAID, and we asked them to run a specific test for us. So when you have a question such as this, email someone who specializes in the field, give them a case presentation, just tell them what the case is, and ask them if they think it fits with the disorders they're used to dealing with. In this case, once they heard about the case, they were agreeable with us regarding the presentation, that it was likely what we were suspecting, and they ran a specific test for us, which was anti-cytokine antibodies. The particular problem that she is dealing with is that she has antibodies against GM-CSF. When you have antibodies against GM-CSF, it impairs the function of macrophages. Remember, GM-CSF is required for making monocytes on macrophages. As a result of this, she developed this specific secondary immune deficiency, and she was treated with a long course of antibiotics. The lesion has resolved, She remains at some risk for developing future infections. She also is at risk for developing a disorder called pulmonary alveolar proteinosis. But now going forward, we know what we are dealing with her. So that's her brain after treating her with almost 3 months of antibiotics. So the 3 patterns that I highlighted were, if you're dealing with encapsulated encapsulated cocci causing sinopulmonary infections, suspect a humoral immune deficiency. If you have candida, mucosal candidiasis, or invasive fungal infections, suspect there is something wrong with neutrophils, neutrophilic inflammation. If you're dealing with intracellular bacteria, then you're dealing, especially causing abscesses or invasive diseases, then it localizes to the Th1 side of inflammation. A couple of other patterns, if you're dealing with unusually recurrent, invasive, or disseminated viral infections like disseminated herpes, disseminated varicella, then your likely locus of problems is T cells, natural killer cells, or type 1 interferons. Cryptosporidium or toxoplasmosis, you're suspecting T cells such as an HIV. And if you have parasites such as Giardia that are really difficult to treat, also suspect that they could have an immunoglobulin deficiency. So
I think we need to stop. It's already 5 o'clock.
So I'm going to go to one other case, and then I'll wrap this up. So this is a case of
A little rapidly, huh?
Okay, this is a patient who presented with initially with severe diarrhea as a child. Then she had a history of frequent ear infections, frequent gastroenteritis. In her 20s, she developed acquired hemophilia. And she also presented with frequent sinusitis and bronchitis. Then she started developing Giardia, and she was diagnosed with CVID. Acquired hemophilia is an extremely rare autoimmune disease. This was actually published, but her diagnosis of CVID was missed at the time. She then developed another immune deficiency disorder, which is membranous glomerulonephritis. And this was treated with Cytoxan and rituximab, resolved. And she then developed autoimmune neutropenia. Ultimately, we did end up making her genetic diagnosis, but notice how many different autoimmune disorders she has developed through the course of her life. She has had multiple infectious presentations, but she's also had multiple autoimmune presentations. Autoimmunity is an integral part of immune deficiency disorders, and if you look at the spectrum of all immune deficiencies, then you have a spread of both infectious susceptibility and autoimmunity. So to summarize, there are typical patterns of unusually recurrent to severe infections or autoimmunity that can help with the diagnosis of primary immune deficiency diseases. There are some resources you could use. And 2 particular things that I would like to point out are the phenotypic classification and immunodeficiencysearch.com. The first contact point for immune deficiency patients is often not the immunologist. So it's very important for everyone to recognize when they're dealing with one and to refer. Above all, if you're dealing with one, collaborate. And with that, I would like to thank everyone for their attention, and I would like to know if there are any questions.
Thank you, Manish. Truly a great presentation. The last case actually showed the importance of a rheumatologist and immunologist across the different specialties. This patient must have gone to a gastro, then must have gone to ENT, then a hematologist, then a nephrologist. I can wonder, this is exactly what I was trying to say, that we actually infiltrate into different specialties, but we see them at the end after they referred to us for different industries. I can take a few questions in the chat box. I'm not sure.
Before, just Professor Das, before we go for the few questions from the chat box, I am disappointed I'm disappointed because I'm a urologist looking for some neurological disorder in urology. Anyway, in a lighter vein, I mentioned that. Before we go for the few questions in the chat box, I would invite a few of our luminaries who would be mentioning about some observation they'll mention, some observation about their experience in immunology, very briefly. At the beginning, I would like to invite our Dr. Ramnath Misra, the popularly called as Munna Bhai MD. I will not say MBBS, Munna Bhai MD. So, Professor Ramnath Misra, please.
Thank you, Dr. Sir. Thank you, Vidyut, for inviting me to be part of this big exercise and a series of events that are going to come. Like what Prasandeep and Manish said, I don't know what, but there is something in SCB that I remember more than any other institution I have passed through. Maybe it may be the cases, it may be our teachers, it may be our colleague, but something that SCB taught me that none of the other institute I passed through, I mean, there was a sense of disconnect with other institute. I mean, you're part of that, but you don't develop that kind of fun. The teacher that we had, and I'm ever so grateful. And I'm ever so grateful to colleagues like Datteswar and Vidyut. Datteswar I knew more in the cricket field than in professional field. He turned out to be a great hero of mine in subsequent years. But I must thank. I'm lucky to be part of SCB. I exactly cannot pinpoint what is it, but that is where my mind, my soul is. Coming to the program that Vidyut was saying to me the other day, there are a series of events being planned and being planned in a very big way, with probably that is the biggest excitement during the Corona time. It has been a very depressing 1.5 years of the pandemic, and the SCB, the thought of having an alumni group, this coverage of or hosting of several academic events, I would, it immediately comes to my mind, why not a series of cricket matches?
That is very much in there, that is very much there, sir.
Because both Datteswar and Vidyut are so classic cricketers that sometime we had a lot of fun. Regarding the subject, I realize that all topics are interesting, but what immunology help you is to go down to the basis that sometimes you would be missing. I mean, if you want to really deep mine the clinical manifestation, the lab abnormalities, your understanding of immunology makes it easier to comprehend, and it adds clarity. And we saw that in the COVID times. Of course, immunologists were not consulted, but all the key therapeutics, the management strategy was down to immunological aberrations or the virus-host interaction. So thank you, Prasandeep, Manish, and most importantly, Vidyut, for organizing this series of cases. I find some of the cases they presented would be challenging. to say the least, to any clinician. And it's not easy. I mean, unless you have what Manish said, that it is there in your mind, you can do mistakes and mistakes.
Thank you. Thank you.
Thank you,
Thank you.
Dr. Swara and
Yeah,
Vidyu.
thank you. Thank you, sir.
I so love to be part of it.
So you are part of it. You are part of it.
Thank you. I hope
Thank
we'll have a physical congregation.
Yeah, sure. Thank you, sir. And before I go to Dr. Alkendra Ghosh, who is our esteemed president of the IRA, Indian Rheumatology Association, I would request Dr. Koniti Rao to have a very brief observation.
Oh, thank you. I was actually my last slide of my talk, which was recorded, and I am told audio was not very good, showed Professor Hazari and a giraffe and a deer drinking water. And that is exactly my point is collaborative clinical research is very important. Here I'm really gratified that Manish mentioned my current boss, Dr. Steve Holland, who is the division director of NIAID in the presence of, in the context of a complicated primary immunodeficiency. And that is exactly what I have been swimming in the last 20 years or 25 years now at NIH. And I happen to be a pediatric hematologist by training. So many people don't even know that I do immunology on the side. So that is my side hustle. And I have tea with immunology, rheumatology, and we all sit and discuss cases. And I come from a boutique institute called National Institutes of Health, which is an intramural program. And I'm so glad SCB is coming to a point where people are talking about rare genetic diseases, because whenever I talk about rare genetic diseases to any of my contemporary classmates from any part of the world, they think I do some grant reviews at NIH and rare diseases, who cares? Nobody cares. But actually, rare diseases are not rare as long as Manish rightly pointed out, if you know how to identify them. I heard Behçet's disease, I saw STAT1 gain of function, loss of function. And I think some of these I mentioned only in the passing because my topic was ITP, and rightly so, because that's what I manage is cytopenias, complicated patients with PID. That's my specialty. So I'm so glad to see everybody coming together. And I was actually there in SGPG. Munna Bhai was kind to host me, and I love him. And he's the Munna Bhai way before Sanjay Dutt made that movie. So we all know him.
Thank you, Koniti. But add Munna Bhai MD. Don't say Munna Bhai MBBS. So now it is my privilege to invite our esteemed Dr. Alkendra Ghosh.
Yeah, good afternoon. I'm really honored to be invited here, and I enjoyed it. The crosstalk between immunology, rheumatology, and the other disciplines, and clinical immunology at this point is always giving us the opportunity to ask why it's happening and what to do. So as PD and Manish gave us a lot of impetus to look for various clinical problems and to look deep into it through the clinical immunology perspective. And I think it is the high time, as we have already started from East Zone Rheumatology Association, the initiative to stimulate the undergraduate students, because that is the point where people should start thinking. And myself, Bidut, Kakoti, and the peoples here, with all supports, we have already covered around 8 to 10 medical colleges. And for the MBBS students, we had the rheumatology program. So I think that's the point where people should start thinking of clinical immunology, rheumatology as a prime discipline to look for internal medicine. And SCB Medical College, the celebration as they're doing through this clinical problem, I think will enrich the people who are participating. And I myself learned a lot. Thanks to you, Dr. Sharawat, Bidut, and all my friends. And I'm really grateful. Thank you so much.
Thank you, sir. Before I hand over for the proceeding of the question and answer, I've got few announcements, very small and quick announcement. Most likely in our Platinum Jubilee year, we are going to have postdoctoral course in clinical immunology. I think that is a big event in the Platinum Jubilee year. We are going to have it. And secondly, I would like to extend again a warm invitation to all of you. We are most likely going to have physical if the corona is, situation is better. If we don't have also, please join us. I invite all of you to please join us in our celebration from 26 to 28 November. Everything will be live streamed. Please join us. And the third appeal, all the alumni, please come back to your alma mater and become a registered member. Thank you. Professor Das, your platform now.
Yeah, thank you. In the chat box, I could see only one question. So I can understand immunology must have knocked them out to a certain extent. There's only one question from the pathologist Pranati about disseminated BCG. What is your experience about the causes? Konetti has answered that. He said disseminated BCG is a common first manifestation of PID and SCID. Manish, you have any?
It depends on it really depends on the age group of the patient you are dealing with, but it absolutely should be investigated for primary immune deficiency. I'm assuming this is a child that has the infection, but there's a whole bunch of different disorders that can present with primary immune deficiency with disseminated BCG. I think the first investigations you could check are easily doable, which is cell counts and you can check immunoglobulins. But this is usually there has to be a problem on the T cell or macrophage side of things. And disseminated BCG or any non-tubercular microbacterial infections that are unusually severe must be investigated for primary immune deficiency. And if the patient is an adult or older than or presenting for the first time at 20, 30, 40 years of age, then the particular disorders that have been described that could lead to the susceptibility have been described by, as Dr. Rao mentioned, by his boss, Dr. Steve Holland, and I'm happy to send some of the articles that are associated with it. But this would be one of those times to reach out and get a proper investigation for this patient.
Thank you, Manish. I don't find any questions in the chat box. So I think we have reached the time limit. I enjoyed my session, and I'm sure all my colleagues, friends across who came to attend this session must have been extremely happy with this. Before I leave, I must say one thing to my mentor, Professor Mishra. Dr. Mishra was my first teacher when I first went to SGPGI. He told me, because right away, and I'm telling this because he was a cricketer, star cricketer of SCB when I joined. And when I took over, he was extremely annoyed with me. He said, how did you get better than me in cricket? When he went away to SGPGI Lucknow and I joined him there, he said, you've come from SCB. Okay, good, good, good. First thing is you know nothing. You start from scratch. I realized that when you say that you really don't know anything, you start learning. I was an assistant professor. I didn't know anything. And of course, I did a lot of immunology later on. So my message to the students and everybody is start with a clean mind and start learning. There's nothing, people get scared of immunology and genetics, but I don't think they should be. But this is a wonderful, one of the most fascinating subjects that I've ever come across. Konetti would agree with me. So this is something that challenges your mind to a great extent. Thank you very much for attending. I'm truly indebted for your presence here, Manish and Prasandeep, as well as all Professor Orkendo Ghosh, Munawar Ramna, Professor Mishra, Dr. Konetti, all the people from the East Zone, including Kakadi. Thank you very much. I hand over the mic to my colleague, Dr. Soumya Ranjan, to give a word of thanks.
No session is complete without the vote of thanks. So it's my honor and privilege to have been given this duty to propose the vote of thanks. Before I start with the vote of thanks, I must congratulate SCB Medical College, the SCB Medical College Alumni Association, for conceiving this mega academic fest, which has brought us all together during this very depressing pandemic and has enlightened us and has brought excitement to one and all. On behalf of SCB Medical College, SCB Medical College Alumni Association, and the Department of Rheumatology, which has organized this CME, I must express my sincere gratitude to our esteemed guest speakers, Professor Dr. P.D. Rath and Dr. Manish Ramesh, all the way from America, who has spared their valuable time and have enlightened us with such rare and beautiful cases, but which have brought us the golden message: always, always, always go to the history taking as a basic of your clinical medicine. Thank you again. This knowledge is definitely going to benefit us all in managing our patients. I would also like to thank the Telemedicine Resource Center, SCB Medical College, Cuttack, for the technical backup, without which this CME would not have been possible. No vote of thanks is complete without thanking the audience. So I would thank all the participants, the learned participants, my teachers, colleagues, students, and all the stalwarts of rheumatology whose interactions has actually brought the charm to the CME. And finally, I would conclude my vote of thanks by expressing my humble prayers to the Almighty to keep us united, safe, and strong, and help us making our lives a success, and also wishing the best of luck to our own Platinum Jubilee. Thank you all.
Thank you. Thank you so much, sir.
There was one more question asked later for the nocardia case. Yes, CGD was ruled out.
Sorry, I must have any difference of info. We can discuss later on. I can pass on the question by email to you.
Thank you.
Okay, fine. Fine.